My name's Sam Klempner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston, Mass. Yeah, the role of genetic testing in the management of gastric and esophageal cancers continues to evolve, as does the broader role of genetic testing in oncology and multiple non-cancer fields as well. Certainly, we've seen some epidemiologic phenomenon, such as rising gastric cancer rates in some select populations, interestingly, particularly young women. And this really kind of brings home the point and reminds us about the importance of consideration of genetic testing when we see our patients at the first visit. Broadly, it's estimated that about 5 to 10% of gastric cancers have a familial component, and about 3 to 5% are actually associated with an inheritable predisposition syndrome. We actually can all do much better at taking a good family history to really help risk stratify patients for further consideration of germline testing. For gastric cancers, the current guidelines are to discuss and refer patients who are diagnosed under the age of 40. Similarly, patients 50 years or younger who have first degree or second degree relative who is diagnosed with gastric cancer should be referred for genetic testing. Beyond these groups, there are actually several additional populations that warrant attention, including patients who have a family history of Lynch syndrome or other GI or GI polyposis syndromes, and of course, patients with a known familial history of hereditary diffuse type gastric cancer, which is related to truncating alterations in the CDH1 gene. Speaking of heritable syndromes, the major heritable syndrome in gastric cancer is hereditary diffuse gastric, as I said, which is mediated by truncating alterations in CDH1, which encodes a tight junction protein E cadherin. The lifetime risk actually varies a fair amount by the specific alteration, but numbers to keep in mind is that these patients have about a 70 to 85% lifetime risk of developing gastric cancer, which is unacceptably high. And the majority of these patients will present with disease before the age of 40. These are the patients where you hear, and we often consider and recommend prophylactic total gastrectomy as a risk-reducing strategy. Like many inheritable cancer predisposition syndromes, CDH1 is an autosomal dominant inheritance pattern, as are the most others associated with gastric cancer. Additional groups, of course, to be aware of are the Lynch syndrome patients, familial adenomatous polyposis, Peutz-Jeghers, and other juvenile polyposis syndromes. These are less common, but certainly should raise a red flag in terms of referral for genetic testing. And there are some sort of non-classic gastric cancer syndromes where we do need to think about this, and this includes BRCA1, 2 families and carriers, Cowden syndrome, patients with Li-Fraumeni. If you actually move up a little bit from the stomach into the esophagus, the vast majority of esophageal cancers are sporadic, particularly esophageal squamous cancers, where these are overwhelmingly related to environmental factors, though genetics should still be considered in young patients. Patients with familial Barrett's, Fanconi anemia, and very rare syndrome called tylosis, which a lot of overgrowth of keratin, are known to be at increased risk of esophageal cancers. One pattern, sorry.
You can just pause if you want, and then just give yourself about 5 seconds. You can start right where you stopped.
One pattern we repeatedly observe with the increased use of panel-based tissue genomic testing, as well as plasma-based panel testing, is that we have probably underappreciated the portion of patients who carry a germline alteration. And this may influence their individual risk, although we're still working to define what some of these variants mean at a risk level for individuals. In clinical practice, we frequently extend our germline testing beyond the guidelines that I mentioned. as we work to generate more data to try to understand and refine the risk for some of the less common subgroups. So in my own practice at our institution, we offer germline testing and genetics referrals to the majority of patients under the age of 50, even those who exist outside of the standard guidelines, such as the NCCN guidelines in gastric cancer. This is partly because we're very interested in contributing to the body of literature to understand some of these rare variants. And we also consider some patients who fall in older categories but have substantial family histories. I think this is an area that will continue to evolve. And actually, we rely on our genetic counselor colleagues who are most up to date with this literature to help continuously refine our guidelines. But I think it should be a consideration in strong family histories, young patients, and any patterns that seem unusual may warrant germline analysis.